Thank you. Okay, if no other comments, I think thank you very much. We'll see you later on again, so you can move to the next session. So I think it's the perfect timing after this talk on bifurcation and osteal circ and osteal LAD. We thought we'll present the actual cases of osteal circ and osteal LAD and see, get the comments on how it should be treated, either osteal stand coming to the left main or not. So I think very interesting two cases, and we will discuss those cases. So for the first case, I would like to invite Dr. Zubair Akram to come and present the case. It's a true osteal circ lesion, and we'll present the case, then we'll have the discussion, and then he'll tell how he did it.
Thank you, Dr. Bashir. Obviously, it's a dilemma for the interventional cardiologist to deal with 001 lesions, as wherever it is, but it becomes even more complex if it's involving the LAD osteal or the circ osteal, and more complex if the circ is a dominant vessel. So now I'm going to take up a case that is the treatment of isolated osteal circ stenosis. Can I have the next slide, please? Next slide. Okay, I don't know. So it's the video I am going to show you is a 38 years old male presented with typical chest pain. He had normal renal functions, no other comorbidities, non-diabetic, non-hypertensive, just a positive family history. And he presented with acute coronary syndrome with the chest pain, and ECG was unremarkable, short bedside echo showed, and ejection fraction of 50%. And troponin quantitative was done, which was significantly raised. ECG was unremarkable. So just getting to the history and the raised troponin, we went ahead with the angiography. So this is the first shot. You can see it's a epicaudal and a RA caudal view. From the right, from the first shot, you can see it's almost a normal looking left main. It's a trifurcation. And this circ is a tight osteal, and it's a dominant circ. Then we have got an intermedius, which looks like having a mild to moderate disease, and LAD looks disease-free as far as the ostium is concerned. So, the patient, young one, coming with this sort of a situation, dominant circ, trifurcation, tight osteal. So over to Dr. Bashir and the panelist. How would you approach the case?
Okay, so very, very interesting case, true. I would say 001, and dominant circ, only ostium, left main, and rest is clear. So from the panelist, Numan, if I ask you, how would you deal this patient if you were doing the case at that time?
So now you can see, this spider projection as well. Now it's very clear, it's a moderate intermedius and this dominant circ with a tight osteal. Thank you. Over to Numan.
Needs to be addressed, obviously. I think imaging definitely will help to see how much of the plaque in the ostium, the left circumflex, is extending into the left main. If left main looks free of disease and not much plaque extended to that, then you can try to nail the stent in the ostium of the left circumflex. The other things to consider are drug-eluting balloons, although there's not good data behind it, but that's something, a consideration over there as well. Obviously, after you get good result with angioplasty, then you can consider without residual stenosis a drug-eluting balloon option over here as well. But nailing the left main, if there's no disease on IVUS imaging in the left main, not much plaque extension would be a reasonable consideration. If there is significant disease, on the IVUS significant plaque extending, then you would have to change your strategy.
Dr. Tariq, you are so fond of, this cutting balloon and high pressure open NC, which we rarely use, but you are very fond of these sorts of gadgets. So over to you for your comments.
First, I would like to differentiate from the SCAD because all the coronaries are looking normal in young patients, so it could be a localized dissection. So IVUS will help, either it's a disease segment or it's a dissection. And if it's a atherosclerotic disease, because the left main is a very large vessel, so technically it's not that difficult. We need to save that and stent because it's a very large left main. So projecting a few struts across the ostium of ramus and then stenting. But first
you
we
won't-
should
you won't come
differentiate
into
whether
the
we should
left main.
stent it or leave it alone.
So you won't come into the left main?
No.
Okay.
Dr. Asad?
I think that, so again, I was definitely important. So luckily, I think when you have an ostial circ lesion, for me, I am actually hoping that it's a dominant circ and not a non-dominant circ, because if a non-dominant circ, you're always in the dilemma whether you come into the left main or not. For this sort of a lesion, luckily the OM ostium has less than 10 millimeter lesion, so definitely wire the OM cutting balloon of the ostial circ, and then I'll definitely bring the stent back into the left main. So if I have to bail out the LED or the circ, I can, I have a balloon, place for the balloon to come back into the left main for tap or whatever I want to do, a cool out or whatever. So for this sort of a thing, I'll always bring the stent back at least to the mid left main, or to help me bail out later on if I have to.
But there is a lot of discrepancy, mismatch between the left main and
I
this.
think you can easily put in a 3.5 stent in the circ, and then for a 3.5 you can easily, if you put a Zions or something, you can push it to a 5.0 with a pot balloon.
Okay. Dr. Kenny?
Yeah, it's a very tricky situation. It's a very dominant circumflex, and the trifurcation, I think I'll do the same. I think I'll just pull the stent, I'll do the circumflex, dominant circumflex, and put the stent in the trifurcation as well, and then put one stent in the left main, and with the provisional kind of stenting, and if the bailout kind of a thing, then I'll do that. But I think you'll have to be, keep yourself prepared for all the kind of worst thing, because a huge left main stem, you have to have the right side of the stent on your shelf all the time, and then all the complications where you anticipate while you are doing all these procedures that should be in your mind.
Dr. Babar?
Yes, I partially agree with Dr. Asad Akbar, but what I will do is put 3 wires in all of the 3 vessels, because it doesn't look like a simple case, it looks a complex case. Especially the rambus intermedius or the high OM also has a disease, and the circumflex is a dominant vessel, and the plaque can shift to the LED, it can go more into the rambus as well, and after putting 3 wires, then we can, I think, put one balloon into the rambus, keep it there, and stent the circ.
Okay,
So
thank you.
that will be my initial strategy.
Okay. Dr. Ramesh, Ramesh, are you there?
Dr. Ramesh?
I think he was there earlier. Okay. So, any other comments from the audience?
Any comments from the audience? Yes, there is somebody there, you know. Just introduce yourself first.
My name is Javed Tai. I'm from Khan University Hospital. I think in this sort of a situation, one thing would be to consider imaging first to see the extent of the disease, whether it's extending into the left main. One possible solution in this situation could be a cutting balloon followed by a DCB rather than considering stenting, because once you go for stenting, positioning of the stenting may be a problem, and if the left main LED are disease-free, then stenting, doing a bifurcation stent, may not be the best option in this situation.
Okay, thank you. Okay, so you can move.
So you know, there were multiple comments. You know, Harun talked about 3 wires, Nawad and Tariq Shafi talked about imaging, Asad also, and Kenny Sab also, and then obviously Asad thought maybe getting into the left main. Rest of them, you know, going just with the just a nailing sort of a situation. So you know, this is how we approach the case. So, you know, what we did was, first of all, the first thing which we did was to get to a 7 French guide. Initially, the angiography we did was 6 French guide, and obviously the radial artery was not too good. And to get a better support and to get a, you know, better 7 French guide, you know, we switched to this femoral approach. And as you can see, and as recommended by Dr. Harun, you know, we had put 3 wires. And then, obviously, as everybody was saying, imaging. Obviously, you can see the imaging. It's the IVUS catheter going into the circ, and then you can see the pullback. Now you can see there the pullback from this pullback to the of IVUS, and then as it gets to the ostium, obviously you can see a big plaque, And then obviously the distal reference diameter, obviously we circ ahead of the lesion, it was 3.5. And on this left side, you can see it's the ostial circ pic, and obviously it showed a big plaque, and a very, very severe narrowing of the ostium of the circ.
We didn't see the left main. Was the left main free of disease? Because
Yeah, you can see, there left main was free of disease, it may not be visible. Then what we did was, then obviously as it was a San French guide, we got this IVUS now on the LED wire. And first of all, we introduced a stent. It was a 3.5 stent in the circ ostium. And what Numan was telling, we decided to deploy this ostial circ stent under IVUS guidance. And you can see we are just right there in the ostium of the circ. And if you can see this 3 o'clock position on your IVUS mode, you can see the stent right there. So, we were quite accurately placed there at this 3 o'clock for the stent, And, there you can see, it's a stent going there. So that was our strategy, as Numan was suggesting, doing ostial circ stenting with 3 wires in and under the ultrasound guidance, IVUS.
There seems to be a lot of plaque in the LED on that image.
Yeah, we will be showing you again those plaques. There is some plaque, but not this, just mild to moderate. So there it is, So, we did this stenting of this, and after that, you can see that is post-stenting IVUS imaging, and there was a bit of a bell apposition, there. And then, you can see a bit of a bell apposition at the circ stent, but obviously circ otherwise is nicely dilated. The ostium, LED is not pinched, and the ramus is also, there, So then we did a post-dilatation of this with 3.75 balloon. Once again, all the 3 wires there. And then, you can see a post-dilatation of this. And now this is the final run at the circ ostial, which was there, and it's a nicely opposed stent. So this is the final picture. And you can see it's a nicely opened circ, obviously mild to moderate, not much of, progression of this plaque into the ramus, this. As far as you were telling about, this LED ostium, there was disease, but obviously it was just about 30 to 40% plaque there. And we decided not to touch it. We just wanted to be absolutely safe because it's all left system dominant. And obviously we were having a good, nice result, so we stopped there and then,
So where there is some pinching of the ramus intermedius.
Yeah, you can see. But obviously, just considering it's a dominant circ, just for cosmetic reasons.
Would it have been better if you could do a kissing over there with the ramus and the...
To kissing, you mean a V-standing sort of a situation, it's not very much applicable. You can see it's between the circ and ramus. You can see it's an angle of about 90 degrees.
For a pin side branch,
it's very focal. I wouldn't really do the balloon because doing the balloon in that area, you are causing injury and resulting in restenosis in the future. I think if you do FFR, it may be definitely
exactly right.
negative.
FFR could have been done.
So, I mean, it's difficult to cross with an FFR wire, but the studies that have been done, if you more than 75% stenosis in a side branch, only 27% of those had actually a significant FFR. So most of them, if a decent sized branch only, then you would consider, even in those branches, only 27% had angiographic appearance greater than 75% stenosis, only 27% significant FFR. So most of them, if it's TIMI-3 flow, as you left alone, you leave them alone, don't need to do anything, and patient is
But ramus is a sizable vessel.
Thank you.
We have to move on because they're ready will be ready for the live case. I think LED, I personally probably would not have even put the 3rd wire in the LED because LED ostium has some plaque but it's free of disease, and especially if I'm trying to do ostial, it's unlikely that you're going to need anything. But excellent demonstration of IVUS and osteal nailing of the very complex disease. Thank you very much. And next, I would request Arslan to come and show the osteal LED case and how he did it. And then we are going to go to the live case from Singapore. They're waiting.
So just a brief history. So this patient was a 42 years old male, and he had a PCI to LED in 2015, back in 15. Now he presented with worsening angina. ECG was unremarkable, so we decided to go ahead with angiography. And these were the initial angiographic shocks. As you can see, I'm not sure if you can, you are able to recognize the stent over the left LED ostium. So there was actually a stent at LED ostium, which seems to be occluded. Or the video is playing there. So this is a flush occlusion at the ostium of LED involving a stent that was placed in 2015. So the patient didn't infarct this time. So our supposition was that this was a gradual sort of restenosis, not stent thrombosis, because the stent was placed in 2015. And if you look at these RCA injections, you can see that LED is filling retrogradely, so showing that the LED has been collateralized over time, and this was a gradual restenosis getting up to the total blockage of the stents. So now, and the LV is also preserved, so it has not infarcted. So how would you manage the case? So it is a total occlusion at the LED ostium involving a gradual re-occlusion of a stent.
Let's get two quick comments before we move on how he did it. Asad, how would you proceed with this case?
I think a couple of issues. First, that there is an sort of ISR of that ostial circ as well. So definitely.
Sorry to. Do you think this is ISR because it's like
It's an
8 years
underdeployed
after
stent,
that?
maybe
So
a
it's
smaller
just
stent that
process.
has been put in,
Okay.
probably on an under-prepped vessel. The question now is whether you should try stenting the LED or you should consider cabbage at this point, because if there's a stent failure already in the circ and you're gonna have to fix that as well as fix the LED. So maybe cabbage is one option that you should consider in this case. Secondly, if I was to do this, obviously wire the LED first, and then I'll probably optimize the circ before I do any strategy, probably a decay crush or something. The problem with decay crushing is you'll end up with 3 layers of stent at the circ ostium because you're going to stent it again. So probably provisional across into the LED.
Ostial circ
No,
has a
circ-
stent?
No.
circ doesn't
Ostial
have a
circ is
stent.
almost
It's
disease-free.
LED
It doesn't have a
sorry,
stent.
to
The
me-
stent was at LED ostium.
LED ostium. Okay, because
there wasn't
the
anything
image
at the
to
circ
me,
ostium.
looked like it was in the circ.
And obviously, surgical option was considered. The patient was discussed about it, and he was of the view that he wanted us to try for the interventional approach first before
then
he goes to surgery.
definitely optimize that stent first, maybe NC balloon or a cutting balloon before you put in another stent, and then a provisional stenting strategy from left main to LED.
Naman?
Yeah, I mean, off-pump lima is always a consideration if it's a stent failure in osteal LED, so that should be discussed. If he's not willing for that, then, likely left main to LED, provisional approach, but imaging will help define how, if you need to go with 2 stent, if it meets the complex criteria. But initially, by visually, look like that would be the strategy to go for. And in terms of if it's in subacute occlusion, chronic occlusions, it's and you can start with don't have to go with the dedicated CTO approach, but start with a pilot 50, probably feel the lesion and then go further in terms of how would you proceed with that. But dual injection.
So we tried to cross the lean with 100, cross it 100 XT, and we were actually able to advance the wire down to the LED. And after some pre-dilations, this was the result. So we were left to this situation. Now the question comes how many of you would like to nail this LED and how many would like to go ahead with crossover stenting?
Dr.
So just short comments, please.
What would you do?
From the left main to LED. It's difficult to nail here, from left main to LED, provisional. And then finishing with kissing balloon.
So size, there is a significant size mismatch. So what size stent would you use there?
I will size according to LED, probably 3.5 stent will be okay for us.
Okay. Dr. Kiani, would you do the left main to LED?
First, the cutting balloon preparation for the...
Yeah, I think it's a big left main. I think it should be a 4.5 or 5 stent with this kind of left main, so left main to LED. The other thing is that it's infarcted.
No, it's not infarcted because the anterior wall was moving on LV.
There was
patient
some kind of
didn't infarct.
hypokinesia in that.
So-
and
There was some hypokinesia, but
I'm
patient
sorry,
didn't infarct.
actually
ECG was also.
they are ready in Singapore. Quickly, just show us what you did.
So we decided to go ahead with osteal nailing, and we were actually able to place the stent right where we wanted it to be. Then we did post-dilations, and these are the final shots.
What size stent did you use?
3.5. The initial stent was 3.0. Now we use 3.5 and post-dilated it with 3.75 NC. And these were the final results. The circumflex ostium was preserved as well.
Did you do IVUS or anything?
No, no imaging was done in this case.
So any, just one comment from
Yeah, I
panelists and
think
then-
again, I think it's a provisional stenting is a much better choice than the two-stent strategy, and this is what goes also as far as our environments are concerned and the patient affordability, and number two is option is concerned.
Okay. Thank you very much.
I think it was
both,
it was the right strategy.
excellent,
crossing over from
Harun,
left
sorry.
main to LED. But if you, I don't know which stent you used.
Arun, they are ready.
Was it Synergy or was,
Singapore.
what is it? What was the stent you used
This time,
in the LED? Which
initially it
stent?
was Zines Expedition, and now we opted for Promus Premier.
No, it would have been better for Synergy or Synergy
Exactly,
Megatron,
budget-
because
due to
then you can
budgetary
expand it in
considerations.
the left main most.
Okay, thank you very much. Great, both the cases. Thank you. We are going to go to Singapore now for the live case, where Dr. Fahim and Fahim Jafary and his team is waiting over there for us. So, can we switch? I think Dr. Harun Babar, till they come on, if you were coming to left main, then definitely Megatron or something else
this
would
is
have
what-
been better.
this
But
was
if you are
my
not
point,
coming to
yeah,
left
yeah.
main, then it should be
Because
okay.
it's a big left main.
Yeah, but he didn't come to the left main, so that's why. So, Fahim, can you hear us?
I can hear you.
Fahim, can you hear us?
Can you hear me?
Yeah, can you hear us?
I can hear you. Can you
We are not able to hear you.
Yeah, I mean, we are playing that's their screen, right?
Fahim, can you hear us?
Vijay, I can hear you. Can you hear us? Can you hear us? We are not taking our feed. Okay, we're not taking our audio feed. We're sending the audio.
We can
Okay,
hear you. Can you hear us?
Vijay, can you hear us? This is Fahim. Can you hear us?
Can you hear us, Fahim? We can.
I can hear you. Can you?
Yeah, we can hear you now too. Please go ahead.
Okay, all right, good.
So thank you very much.
Finally,
Let me
Assalamualaikum,
just
everybody.
thank you very much for coming again. Every year you have been kind enough to show us the case, and I'm sure today it's going to be a very interesting case. Also, we have a great panel of experts team who is sitting here: Dr. Noman Nasi, Dr. Tariq Shafi, Dr. Asad Khan, General Azhar Kiani Saab, and Harun Babar. So they are our panelists over here, and we have a lot of audience here too. So over to you. Please introduce your team and the case.
Okay, so Assalamualaikum, everybody in Lahore. Welcome to Singapore. It's afternoon here, it's morning at your side. Thank you for inviting us for this wonderful session. We need a lot of help. We've got a very sick patient over here, and we have a lot of problems. I'm glad that you all are there to help us. Let me introduce all of us. I'm Fahim Jafary. My partner is Dr. Hoswa. He doesn't need an introduction. He's one of the master interventionists here in Singapore.
Fahim, there is a lot of echo in your
helping us
voice.
With this case is one of my colleagues, Dr. Randall Lowe, who's at the back end, Dr. Diana Cruz, You will in a short while, we will go over the iris findings with us. Dr. Deborah Lee, who sort of helps facilitate the case, and the rest of us, and Dr. Bharat, who is also supporting us at the back. We have a huge team over here. Rather than name everybody, I'll just say that we have one of the best teams in the cath lab, and they're all awesome and amazingly supportive.
Fahim, sorry to interrupt. Actually, we are getting a lot of echo. We are having a little difficulty in understanding you. A lot of echo in your voice. I don't know if they can do anything over there.
A lot of echo. They're saying they're getting a lot of echo. So hang on for a second. Let me get the technical people to sort this out. Meanwhile, can we have the slides up there?
I know we are able to hear you, but a lot of echo, difficult.
Lot of echo, all right. How about now? Maybe I move behind. Can you hear me now?
A little better, but still there.
I don't know if the tech people will have to tell us what's going on.
Can we get the slides up?
Let's put up the slides while we're sorting out the sound issue.
Yeah, still a lot of echo. I don't
Still
know.
a lot of echo, Bashir?
Yeah, still there's.
Are you able to see the slides now?
Yeah, I can hear you very well, but as I said, it's a lot of echo, so it's having a little bit difficulty in understanding.
Okay. All right, I'm just asking our technical people to...
You can probably just tell us about the case because you have slides there in the meantime till they try to fix it.
Okay. Okay, so I'm going to ask my partner to go over the case.
Sure.
Good. Okay, next slide.
So, greetings from Singapore, Bashir, and the people in Pakistan Live. So we're going to share an interesting case from our cath lab today. We have a male.
We lost you.
He had residual moderate disease in the LAD and circ, and the subsequent nuclear scan was negative, and he was treated medically. Next slide. Go to the next slide. So he was seen in our clinic in February for angina, and the echo at the time showed that EF was 45% with inferior wall being akinetic. So in view of his known residual disease in the LAD and circ, he was listed for an angiogram in our cath lab. Next. So these are the still images of the patient. You can see that he has a very critical disease in the mid-LAD, and there's some moderate disease in the left circumflex and OM. And the RCA, you can see that it's an occlusion in the mid-RCA onwards, which involves the previous implanted stents. Next. So he was referred for CABG because of the triple vessel disease, and the patient declined CABG. And when we reviewed it in clinic, he was still having limiting angina. You can see from the medications that he's really on optimal med. So he opted for high-risk PCI. Next slide. So we managed to do a CT coronary calcium score prior to the test, and you note that very high calcium score, especially in the LAD. Next slide. So there are challenges with this patient. We have a very calcified LAD. You can see from the image it's a bifurcation, probably a 111 Medina, and the EF is 45%, and we have an RTA CTO. So I'll now pass over to my partner Fahim to discuss about the strategy.
Okay.
Right. So, Bashir, are you able to hear us clearly or not really?
A little better. It's better now. So
Okay,
let's.
As you heard the case, I mean, this is an elderly gentleman with a chronically occluded right corneal artery, akinetic or inferior wall, a critical and heavily calcific LAD, and moderate disease in the so maybe I can now show you the images. So in front of you on the screen is the circumflex, the corner view with the left main circumflex. And this is now the LAD, and I let it play for a second. You can see that there are collaterals going to the RCA, and it's quite calcific in the mid-LAD, south of the diagonal, and is also calcium proximal to the diagonal. Next image, and this is just an audio cranial view. So I'll stop here and see what your thoughts are on this gentleman who is quite unwell, and I'll explain how things went, but I want to know what your thoughts are because we need a lot of input and help regarding this case. What would you do with this?
Okay, so let me try to get some comments from our panelists. Dr. Asad Khan, how would you do it, this case? Because my concern is going to be, obviously there's a lot of calcium, and if you try to use atherectomy and there are collaterals going to the right, you will have some problem with that also. You may have some kind of no reflow, and then you will have only circ left, and EF is around still 45, which is not that bad, but there would be a possibility of patient having hemodynamic compromise. So Asad, there are two questions to you. One, would you consider any hemodynamic support before starting this case? And second, how would you deal with it?
Yep. So great, very complex case, especially the fact that left side is plying the right coronary artery as well. Imaging upfront for sure. Question regarding atherectomy, I don't think there is a question of that. You cannot do this case without atherectomy. You'll have to do it. You don't want an underexpanded stent in that LAD when it's the main vessel supplying everything. But you probably will need to IVAS that diag as well to see if you need cutting balloon or can you just do it in an NC balloon. Definitely, whatever hemodynamic support you can get. I see a balloon pump there already on the latest images, so probably that's what they've gone with. Impella would have been even nicer, but again, depending on availability and stuff. So imaging, atherectomy for sure, and then hemodynamic support for sure, yes.
Numan?
And a 2-stent strategy. Yes.
Okay.
I mean, it has the cramp-track appearance, a lot of calcification. Fluoroscopically, you don't need IVAS. I mean, you wouldn't need imaging, but IVAS to tell you that this case needs atherectomy. The only issue is doing atherectomy, you don't have a wire in the side branch, and when you're doing that, there's always this risk of losing the side branch. And any thoughts on that? Asad, you use a lot of rota in terms of, you know,
I think
what about the diagonal protection when you're doing that atherectomy?
So actually with atherectomy, the chance of preserving the side branch are better because you are shaving off the calcium. So plaque shift is actually less until you actually NC balloon it after rotablation. So by that time you can have the wire in. And there is no, there's TIMI3 flow in that diag. So hopefully you should be able to preserve that.
Okay, Fahim, so you tell us what's your plan.
Those are great thoughts, and our thought was sort of on the same lines. We felt that this is heavily calcific. We knew that already from the CT calcium score. We felt that it is likely to need atherectomy, but we just wanted to image it to know what sort of atherectomy and how to go about it. So I'm going to pass this on to my colleague, Dr. Diana Cruz, one of our consultant interventionists, who will just go over the IVAS findings with you. So can you see the IVAS on the screen? Yeah, there you go.
Okay, thank you, Dr. Fahim. So this is the IVAS run pre-PCI. Distally, you can see that there's a little bit of a myocardial bridge before you have a bit of fibrous plaque. You can see some septal branches coming in there. And then you start seeing some of the calcification. So near concentric calcification here. A very tight lumen where the lesion's hugging the IVAS catheter. And again, concentric rings of calcification. So lumen gets bigger here.
Right. So, Diana, at the tightest part where the calcium is, what is the lumen over there, or the lumen diameter?
So this was around the tightest spot that we had. That's about 1.7.
Right.
Yeah.
So clearly quite a bit of calcium, concentric rings of calcium, and we sort of had a bit of a debate and in terms of what to do about it, because it's not, you wonder whether the rotablation would touch it because the lumen is 170. You also wonder whether you should do something else like orbital or should you do IVL. So we decided to go with rotablation, and we went with a 175 burr. And so let me just show you now so we went basically 7 runs. And so I'm going to ask Eric to can you see the screen now, the angiogram? So we went just forward.
Fahim, you didn't consider any hemodynamic support in case of no reflow, or was there any concern about that?
So we put in upfront, we put in a balloon pump. We would like to do Impella. The problem is the cost of Impella. Our concern was that some support is better than none, although, the data with balloon pump is sort of iffy, but we felt that it would be helpful. And so we went ahead and started to burr, and it took a while to cross. I'll just keep asking Eric to forward. So, we kept, ultimately you can see that the flow is pretty good. Next, please.
So you started with 1.75?
We went with a 175 burr, sort of, the distal vessel is about a 3 to 5 vessel, and, so a burr to artery ratio of about 0.5, 0.6. And here's when things started to get interesting. We had him in the lab. He has a history of COPD, and we had him on with the help of our Dr. Chunwei Wong, who's our cardiac intensivist and is gratefully helping us with this case. We gave him sedatives, and pretty soon after that, he became really agitated and essentially started retaining CO2. We were worried that we had done some mischief, and you can see that can you play that? The angiogram after rotablation looks pretty good. There's no perforation. So the next view, you can see that the left main is kind of okay. And so in the lab, then he ended up needing to get intubated. And so he was intubated sort of semi-electively because he started retaining CO2. We thought maybe there was something else going on. So we put a swan, and his wedge is only 18, so not bad at all. So next, please, forward. And this is the angiogram after we rewired everything. We put in a wiggle wire just to get more support. Next, please. And then we re-IVUS. And Diana, can you show us the IVUS after rotablation?
Okay, so this is the IVUS post-rotablation. I'll just forward it to the areas of calcification.
I would like to welcome Dr. Ashok Seth online. Thank you very much, Ashok. Dr. Ashok is the president of Asian Society of Interventional Cardiology. So thank you so much for joining us. We are doing this live case. I don't know if you joined from the beginning from Singapore. Fahim Jafary is doing the case, and it's a basically bifurcation calcified LAD disease. I don't know if you saw the pictures. If you have, then you can comment on that.
If you like, we can show the picture for Ashok. Just go back one. Go to that picture back. Okay. That's no. Stop. Now just show this picture to the audience one more time. Can you see the so that's it's a calcific LAD and a diagonal which is at this stage has been rotablated. So Dr. Diana Ku is now going to show you the post-rotablation IVUS. Let's go back to the IVUS now. There's a lot of background noise. I'm not sure where that's coming from.
Okay, so this is the IVUS on the screen. I'll just forward to the areas of severe calcification. You can see here that there's a crack at about 11 o'clock and 6 o'clock with some luminal gain compared to the pre-rota IVUS.
So I had 2 questions in terms of first, whether to choose IVL versus rota over here. Why did they decide to go with rota instead of IVL? And the other is, in terms of plaque modification versus debulking. I mean, Asad felt he wanted to do more, but if you had gotten 2 cracks in that arc, at 11 o'clock, 12 o'clock position, in different area, 2 different spots, and angiographically looks much better. So you're hoping you'll get adequate stent expansion. I mean, you I guess wanted to do more over there. Asad, what were your thoughts on that IVUS plan?
Fahim, did you hear the question?
Yeah, so if I heard the question correctly, why do ROTA and why not IVL? So we debated that also in our mind. I think we knew that there was extensive calcium from the CT, and there's a lot of calcium on the IVUS. The IVUS calcium score is quite high, and we did not want ROTA regret. We felt that it's best to ablate, because once you dilate, then you kind of often lose the opportunity to do road ablation. So that was the main, we wanted to throw everything at it. The calcium score in the LAD was about 800, so it is pretty extensive and thick calcium. But that is a fair point. Could we have gone with IVL instead? I guess it's always definitely something to keep in mind. Now Diana's shown you that after road ablation, we can see that there's some cracks in the calcium. And of course, at this point, the patient is intubated, and just for those who've just joined in, the patient essentially, after sedation, started retaining CO2 and became agitated. It wasn't a coronary-related issue. His wedge pressure was actually pretty unremarkable, 18 or something. And so now he's intubated, and we then decided that, okay, after some calcium cracks, let's go ahead and dilate this with an NC balloon. I'd be curious to know who would use IVL at this point. So let's go forward to the next picture.
Fahim,
so we went with next, please.
Fahim,
Keep
so
going.
did you check? Did the right heart cath, or did you check the LVDP before the procedure with the wedge pressure?
No, we put in a swan after he sort of needed to be intubated, because I wasn't really sure what the hell was going on, to be honest.
But did you check
but
EDP
it's a good
before
point
the procedure?
An LV EDP would also be just as useful.
Okay.
Next, please.
Let's get comments from Ashok. Ashok, I don't know if you have seen IVUS. So at this point, would you consider doing anything else, IVUS, or go to non-compliant balloon, or would you have chosen IVUS, or rotational atherectomy, or IVL right from the beginning in this case?
Hello, Bashir. I hope you can hear me.
Yes, we can hear you.
It's indeed a pleasure to be with you at the Pakistan Live, and I wish I could be there with you all in person. I mean, I think there's a lot of affection, and I would have just loved to be there. But I'm involved in another meeting, the valve meeting in Chennai, and that's where I am at the moment.
Thank you so much.
My comments here are, from here on, I'd keep it simple. And I'd keep it simple with the fact that as long as I've got PA pressure monitoring and PA sats, by the way, that's what I do very regularly in such situations. I would then move to clearly balloon dilatation to see whether rotational atherectomy had sufficed rather than use more tools. So as long as you have a complete expansion of balloon in 2 orthogonal projections, you've done the job, and that's my clear indication. Not so much as IVUSing, more OCTs, but balloon expansion of an optimal size balloon in 2 orthogonal projections after calcium modification would be my tool, and I think that's what is being done right now.
Okay, Fahim, go ahead, please.
Yeah, those are excellent points, Ashok, and thank you for those. So we went ahead with a 3.0 NC, and I'll just play the pictures rapidly in the interest of time. So that's a 3.0 at 20 atmospheres. Next, please. Another 3.0 at 20 atmospheres. Next. Next, please. Next. And that's a 325, I believe, at high pressure, like 22 atmospheres. Next, please. And this is now in an orthogonal view, exactly as Ashok pointed out. And here, the balloon, if you look at the upper surface of the balloon, it looks, at least to me, a bit underexpanded. So this is where we are right now. And so I'd love to know from the panel, do we re-IVUS? Do we take the same balloon and go much higher pressure? Or do we use an IVL? What do you, we need your help and suggestions on this case, because this is an unwell gentleman and we need to be moving quick on him.
Ashok, what would you do?
So my clear issue is, so what sort of pressures is this at?
22.
And your vessel size, I guess there is a 3.5. You would have assessed that IVUS. And if it is 3.5, I'm very clear that this requires an IVL at this stage. You want complete and good expansions. You don't necessarily need to get rid of the eccentric stenosis, because at the end of the day, you want lumens, but you'll only get large MSAs if you really crack that deep calcium, and I think you can go ahead with IVL, especially in your proximal segment, where rotational atherectomy does an inadequate job, primarily because there is a small burr in a very large vessel. And here is where you actually need your IVLs, more than in the smaller or 3 millimeter size or less vessels after rotational atherectomy. So even in rototrachea, it does work well in smaller vessels than in larger vessels.
I agree 100%, and that is sort of what we were leaning towards versus taking a 3.5 and going high pressure. I think the problem with the 3.5 NC at very high pressure is that you're more likely to dissect it. And as we mentioned, that he became unstable, I think largely from respiratory issues. But at the end of the day, this is a big LED supplying a right territory, so he's quite dependent on it. So we're getting a 3.512 IVL. While we're getting it ready, I'd love to hear any more thoughts and comments on this.
Just one more point, that if you go with a 3.5 non-compliant balloon at high pressures, you're just going to expand on the side where this deep calcium is not yielding, which means the opposite side, risking perforations, and not just dissection, but perforations as well.
Agreed. What about, while we're getting the IVL ready, maybe I can ask the panel for your thoughts on, or Ashok, your thoughts on using OPN in this situation. We used to use it a lot in the past, and now the pressures of 50 atmospheres do worry us a bit. But I'd love to know what the panel's thoughts are on that.
Nadeem, what would you do at this stage? Would you consider using OPN, or just, we don't have IVL unfortunately, but what would be your strategy if you were doing it with the limited things we have?
Yeah, I think I would use OPN. I've probably had about more than 90% success at 34, above 35 atmosphere. I think it will open up usually.
You know,
but I wouldn't use a 1-to-1 size balloon. I think if you have a lumen diameter above certain area, then stenting would be fine. So I think OPN of 3, even if it opens up completely, would be fine.
You know, last 2 OPNs I have used, as soon as I go up above 35, both of them actually ruptured. I know people have gone up to 40 also, but I don't know others' experience, but last 2 of mine got ruptured at 35.
Can I comment on OPN, please? I use OPN a lot, because we've had it for the last 4 years. But here's the principles of my OPN use after calcium modification. Certainly, IVL in such situations falls prior to OPN. Oftentimes, I would modify that with an OPN. I think OPN is a great non-compliant balloon. So just don't think of it as an ultra-high pressure balloon, but it's a great non-compliant balloon. Majority of the OPNs would rupture by 40, but I've used it up to 50 atmospheres. So I think there's chances of rupture which increase. But I must say that in a 3.5 millimeter vessel, post-stent implantation, if the MSAs are not adequate enough, even after IVL, is the choice of OPN, and the OPN should be 3 in a 3.5 vessel going up to 40 atmospheres, maintaining for as long as possible, which could be 30 seconds to a minute, 2 or 3 inflations prior to going up on the OPN size, and it should never be without imaging. OPN at high pressure should always be used with imaging.
So this is the IVL now, and we're going to chalk it.
Yeah.
So what size OPN you took?
You think
Fahim?
so? Yeah, okay. Maybe a little bit.
This is IVL.
3.512.
Sorry, yeah, IVL, yeah, 3.5, sorry.
Okay.
Dr. Tariq, what would you be doing it in this case if you are doing the case?
Yeah, go up here, 4.
First I will make a pre-dilated with 2O NC, then OPN NC undersized 3O at high pressure, close to 30 or 35 ATM. 3.5 OPN is too big for it. The calcified vessel, so the risk of perforation is
tolerating it well.
So better take a smaller balloon and go to higher pressure.
Yeah, there.
So
is there any role of cutting balloon here? Anyone would you consider using cutting balloon?
Cutting balloon, if it passes through this lesion, it's better to do first the cutting balloon and then OPN NC.
Ashok, would you try a cutting balloon before going to OPN if you don't have IVL?
Not at all. Not at all. I think it's a fairly pathetic device. For my practice, it's only for mild at the most moderate calcification, not unyielding calcification at all, and it's only meant for osteal lesions and fibrotic lesions and in-century stenosis, nothing more than that.
And what about combining it with rota at this stage, not just isolated cutting balloon?
Okay, yeah. So let's whack it here.
How many times you have
Four.
come across complication as far as you're using a cutting balloon? Have you ever got stuck with
Come
the
AP
calcium
caudal.
and the blade stuck there over there and
Just
you have a
stay up
problem pulling out the balloon? Question for Dr. Ashok.
Center.
So any problem, did you ever face any problem with the cutting balloon when if your balloon is stuck in the calcium and your blades are stuck in the calcium, you have a problem taking out the balloon from that calcium?
Ashok, this is a question for you. Like if you ever had a problem while using cutting balloon in the calcium and your balloon got stuck there or the blades got stuck?
It's not green yet. It's not green yet.
No, not in a calcium, but in other circumstances, yes, within a stent or in-stent restenosis. But the Wolverine overcomes that very well because I think the blades go really well within, and therefore with the Wolverine we've never faced problems like this. But in my experiences of many years, I have had blades getting stuck in other situations.
In terms of plaque modification, any preferences with, in terms of the cutting balloons, your Wolverine or Angiosculpt or the chocolate balloon, people, some people like any preferences in terms of profile or which one they would prefer?
Ashok, any particular preference for any cutting balloon like Angiosculpt, Wolverine or chocolate balloon, or have you used all or just you stick to one?
No, I've used all, you're right, but clearly the preference is for Wolverine. I think it's a very trackable balloon now, and of course makes much better sense in terms of if you really got to use a device, it has to be effective, and with those blades, Wolverine is the most effective cutting balloon that there is available. So I think it's fair to use a device which is logically very effective as well. There's no randomized comparison between the two.
Let's do the diag,
Okay. Okay, Fahim, so what's going on?
So we've given all 80 pulses in the LAD, and it looks like it's sort of expanded. We have a little distal dissection, but that's not a surprise. So our thoughts are that at this point, we've maximally dilated it as much as we can. So at this point, a good idea would be to address the diagonal. We want to do this provisionally. He's relatively elderly. Unless my hand is forced, I don't think that I want to put a stent in that diagonal. He is quite ischemic. As soon as we went up with the IVL, his ST segments went up. I don't know if you guys saw that or not. Yeah. So that is clearly, he is quite dependent on this LAD. But other than that, his pressure is holding. His PA diastolic is 20, which is pretty good. I still
are
think
you
that
going to NC
the reason
again?
why he got intubated, no, this one.
Are you going to use NC again?
You're monitoring his PA's real time now, isn't it?
Yeah, his PA diastolic. If you look at the screen, the one that says PA in blue, that's his PA pressure, and it's giving us a pretty good indication of where he is. His PA diastolic was never more than 20-ish, but he does transiently go up when we dilate the LAD. So not a surprise.
Fahim, I've always said that you're a very practical operator.
Well, I mean, a guy getting intubated just before we go live was not exactly my idea of fun.
No,
but
those
that's
happen.
just the way it is.
But you've got to predict. You've got to predict all circumstances and deal with them. And I think that's.
My partner is great, and he's and our team, he's helping me to get through this. All right, so that's the score flag.
So, Fahim, do you think that diagonal you really needed to, because it's a diffusely diseased diagonal vessel, and
it's
how
very
far
tight. You're right. It's very tight. So I'm just worried that it may just go down. But yeah, that's I mean, I'm happy to hear what others would do down. I mean, can we get away without touching the diag? That's definitely.
Nadine, would you have done anything to the diagonal or just gone ahead with the LAD stenting?
Yeah, I think it depends on the length and the size of the diagonal and the LV function. In people with the poorer LV function, I am quite a proponent that you should totally revascularize. So the poorer the LV function, the more significant any vessel which is more than 2 millimeter becomes. So in a normal LV function, if it's taking too much time, I might leave a diagonal alone with a 20, 30, 50% residual. But in someone with the LV function which is not adequate, I would definitely do every vessel which is more
2
than
or
2
20?
millimeters.
Yeah. 2 or 20 agent.
Would you have
Yeah,
done
that's a good point. And I mean, at the end of the day, I'm not sure how much of a prognostic benefit there is, but it is a big diagonal. So we felt that it'll be reasonable to just at least open this up with a balloon.
Yeah, my only concern is it's a
I think-
diffusely diseased vessel. If you're not planning to stent and just doing balloon the whole vessel and then dissection and all those problems, going back into that diagonal may be a problem
Well, we're
also.
going to do a DB, so we're going to go one step in between nothing and a stent. And in the hands of my partner, who's one of the world experts in DB, hopefully this will be okay. But I mean, I point taken. And then the other issue is always, for me personally, is that when you have a heavily calcified vessel, even when the side branch doesn't apparently look calcific, there often is a nodule or something over there that precludes you from getting decent expansion. And an underexpanded stent is a far worse proposition. Let's go up here.
May I comment on this? May I just come in? And then I support the dilatation of the diagonal. Firstly, you don't want, you may say this is diffusely diseased. You certainly want it open and you don't want it closed at the end of the procedure. The second thing is I support that whether you use a cutting balloon or whether you use you need to cut it prior to drug-coated balloon.
So Diana, what do you need?
To have a modification with a cutting device. Efficacy is better. And finally, it prevents diagonal closure. We also know that pre-dilatation in such situations where there's high risk of diagonal closure during stent expansions. I think we just have to keep this diagonal open. Otherwise, we have a catastrophic consequence even of losing this diagonal in an impaired LV. So I think the steps are fine, but there's clearly no point stenting it, but keeping it well open and hoping that it stays open in the long term with the drug-coated balloon.
And if can I just make this point, just a little bit of provocative point, but this point about underexpanded stents. You see, in a calcified vessel, just for the fellows, if the area of, there is a difference between malapposition and underexpanded. So if you've got IVUS and your stent is showing 20 to 30% under expansion, let's say residual, and you keep on pushing with an NC balloon and it doesn't expand, or even if there's no harm in leaving it as such if you've got IVUS and you've seen that it's properly opposed. So underexpanded does, if you've got an area of more than 4 to 6 millimeter per square in that, and it's, even though it's not round, and even though it's underexpanded to up to 20%, if you look at all the studies, the rate of restenosis and SAT is dependent on malopposition rather than underexpansion. So this fact about pushing the stent to make sure that it's 1-to-1 and looks beautiful in a calcified vessel, I think for the fellows, you should not push it too much. Leaving a stent underexpanded is okay, provided it is not malopposed.
So actually, if you look at the ultimate criteria, they use the cutoff of 5 millimeter square, that is good outcomes. But the malapposition somehow, as we all thought, was not as bad in the IVUS studies. It was the underexpansion, it was the distal edge and proximal edge disease, where you landed if it was more than 50%. And underexpansion correlated more with stent thrombosis and worse outcomes. But you want it well opposed. That's not the point.
What is the definition of underexpansion? One way you
so
are
if
saying
you get it
that
more than 5 millimeter square or 90% of the distal reference lumen area, it's adequately expanded. You don't need to compare it with your EEM outside. Yeah.
I think we are all saying the same thing. Once you get a minimal stent area more than 5, even if it's malopposed, you're fine.
Ashok, your comments? Did you hear
I just want to show you, this is the Synergy 48, 3048, and I just want, if you can see it on the screen, with all the calcium and everything, it's sailed right through. And so I think that the XD series is very, very deliverable, compared to a previous generation of stents. So Diana tells us that we need a 3048, so I'm going to do as I'm told, and that's what we're doing. Test, please. So one thing we have to be careful is that distally there's a little bit of a myocardial bridge. And so we kind of have to be a little bit in the bridge because of the fact that that's where our landing zone is. And I'd like to know what the panel thinks about landing stents in a bridge when, anything proximal to that is significantly diseased. So I think distally we're okay. We take a cine here. So distally we're okay, and then we come in the caudal view to take a look. So we're pretty well landed there. Come AP caudal, please.
Yeah, looks
we have
okay.
to go in a little bit, so we'll just place it.
Fahim, what about leaving a jailed balloon in the side branch? I mean, I've seen recently that keeps the branch open and stops.
That's very popular these days, Nadeem. I just worry about the thing getting trapped. And, I think I'm in the minority here, but, educate us. What do you think? I mean, we're good, right? Yeah. Come back to cranial. I mean, is that something you guys do routinely? I just worry about in a calcified vessel, if somehow
I
the
would
balloon
not. I
starts
think it's very
catching the
popular in our
stent and
WhatsApp
it
group,
can rip
and
the
it's
stent
good that you
apart,
use that technique,
that's
but I
just
think
not worth
it's not
it. I mean,
endorsed by any guidelines or good data behind it right now, and you can have a lot of issues with a jailed balloon in the
Ashok,
calcification. Would have gone with the stent technique in this strategy with it, it meets all the definition criteria for a complex lesion, two stent, would have preferred that.
Ashok, what's your comments about leaving the jailed balloon in the side branch? Do you use it quite often or not, or what's your views?
I don't use it quite often, and whenever I use it, I use it making sure that my balloon length is such that it protrudes out from the proximal end of the stent. The modified jail balloon, which actually traps the balloon even behind the stent, always worries me. So I always
that worries me too, Ashok. I agree with you. I mean, I just, sort of imagine the nightmare scenario that the jail balloon rips the stent into sort of a mangled piece of metal, and I pinch myself and don't wake up from that nightmare. So maybe I'm too old-fashioned. I don't know.
I think we have Dr. Salman in the audience. Maybe he can have some comments. Is he there? He has been promoting it a lot.
It would be nice for you to relate the best practices around IVL. I think that is another aspect that...
Ashok, did you hear that earlier discussion about malapposition and other expansion versus just looking at the area and okay with it? If it is more than 5, doesn't matter if it is under expanded or malopposed. What are your comments about it?
My view is well, both are important, and let's not just have one or the other. But MSAs are very important, and I just look at MSAs in a huge way. And I sort of even do not. The 5 is for me. IVUS has to be 5.5. OCT has to be 4.5. But OCT measurements, I aim for 5, and IVUS measurements, I aim for 6. So I go even a bit higher than that for my MSAs for mid and proximal segments. I think that's what you got to look at least 5.5 on IVUS, 4.5 on OCT, and even get it bigger than that. You would get, and its symmetry does not matter. After a point, you chase MSAs, and that is why when we go ultra high pressure on an OPN, we must look at MSAs prior to using our OPN. We may have adequate expansion, and there may not be any reason to use MSA because we may be chasing an eccentricity which is unnecessary.
So you think malapposition is worse or under expansion is worse?
I believe under expansion is worse. Malapposition in a large vessel is probably not as bad as under expansion.
I think, Bashir, there's plenty of data that shows that acute malapposition is not a problem in terms of clinical outcomes. 20 here. Late malapposition is a different story. That is vessel toxicity when the vessel wall leaves the stent, and that has different implications. But acute malapposition is not a problem as long as the stent is widely expanded and down. And as, I think Nadeem and Ashok said, symmetry is not a huge issue. This is not cosmetic surgery. If it's oval but good area, I think by and large you're okay. Down.
Okay,
so we're going up with a 3.0 NC distally to post-dilate, and then we'll go with a 3.5 proximally, 22.
Fahim, we have only 3 minutes left, so please if you could.
Okay.
Yeah.
So then I guess we can wrap. Let me just come down on this. Let me just come back on this one more time, and then we'll just show you what it looks like. We're going to post-dilate distally, proximally with a 3.5 NC. We'll see if we need to recross the diagonal, hopefully not. But if we need to, we'll go ahead and do that. And then we'll re-IVUS to look at our area. So let me give you a picture, and hopefully the diagonal is still there. If not, then we have to go back and rescue it. Yeah, the diagonal is still there. That's good enough. Any other thoughts from the panel on this?
Yeah, anyone would go back to do something to the diagonal or leave it like that?
Not at all. I think it's just now optimization of the proximal segment, and the diagonal should stay open because he's done a good job across the diagonal. So Fahim, I think we've done a tremendous job. What a great demonstration of a complex calcified bifurcation.
Dr. Tariq, would you go and chase the diagonal after optimization if the flow is there?
I will do a kissing balloon inflection because it's pitched here.
So you will do like a kissing balloon?
Kissing balloon and drug-eluting balloon if possible.
Drug-eluting balloon, okay.
We've already done the drug-eluting balloon.
He's done the drug-eluting balloon. I must tell you, going through the struts of a stent with a drug-eluting balloon is a no-no. That's why he actually did it earlier rather than later, because he's just going to scrape off much of the drug and be uncertain about its efficacy. So I think he's done what he wanted to do much earlier.
Okay.
And he's got a patent diagram.
So any other comments from the panelists? Dr. Kiani, Nadeem, quick comments because we are almost ready for the next session.
I would have gone for the plain, I think, simple stenting the LED and wire the diagonal and not to do anything with the diagonal. The result would have been the same as after, I think, ballooning it and then stenting it. So I think the simple strategy, single stent strategy is always the best way to go.
Okay, thank you. So, Fahim, are you planning to do IVUS?
Yeah, we're going to just post-dilate the proximal stent with a 3.5 and then do IVUS. I don't know if we have time to show that to you. If you do, can give us a few minutes, we'll do that.
Yeah, if you can do in next 2-3 minutes, then we can wait.
Okay,
Bashir,
let me...
Bashir and my friends there, I must say, what a great case. I have to excuse myself because I have a commitment on the podium at the meeting. But again, love you all. I wish I was there with you, having the fun and enjoying your hospitality. And I'm sure next year.
Ashok, thank you very much. I know you had your own meeting going on and you spared time to be here. And I really, really appreciate coming here. Great comments and thank you very much.
Thanks. Take care. Have a
Ashok,
great
thank you.
Yeah, have a great meeting, and Fahim, great to see you again.
See you.
Thank you.
Bye.
There's a question.
Yeah. Let's take the IVUS.
So any other comments from panelists?
Yes, coming.
Hamza?
Store that, please.
Not really.
So we're just going to do a quick IVUS. If you have a minute, we can show it to you.
Please, quickly.
If not, I'm just very grateful to Pakistan Live and to Bashir and the whole organizing committee for inviting us. And thank you so much to the panel for all their help. And certainly, a lot of thanks to our team over here and to Boston Scientific for supporting this endeavor. They've always been very, very helpful and very supportive. So with that note, I'm just going to go in with the IVUS. Okay. If we get cut off, then we get cut off. If not, then you'll get to see what it looks like and see if we need to do more
one
stuff.
Comment from the
Diana,
audience.
Over to you. If you could just give us a live
Fahim, just
commentary.
1 second. Hamza?
Thank you very much, sir. So I just had, my name is Dr. Hamza Azagori. So since we were talking about the indices on IVUS and OCT, especially in terms of malapposition and expansion, so I think we do have criteria, especially for malapposition, considering the OCT. So if the length is up to 1 mm or more and 0.4 mm, I think that's the cutoff for acute malapposition.
The stent ended well in an area which is pretty clean and not free.
Yeah, can I just make a
Stent appears
comment?
well opposed.
This is what we were discussing, that as you define the malapposition, that's OCT. OCT costs 4.5 lakh rupees of a catheter. 99% of the labs in Pakistan don't have OCT. 90% of the labs in Pakistan don't have IVUS. So I think what you are dependent on is an angiographic thing. So for our teaching, it is very important that malapposition in all studies have never been, like stable angina has never been defined.
That's good, huh?
So it depends on how, if you go into academics, then malopposition, but common sense, mechanistically, if there is enough space outside the stent where there is stagnant flow, you're going to get some thrombus which might propagate inside. So although the studies have shown that malopposition is not as bad as under expansion, but if you got a under expanded stent which is less than 4 millimeter in area, you are going to get a problem with restenosis and
okay, I think, I'm sorry, we have to stop, Hamza. If you can quickly go over the IVUS and then we'll have to say goodbye.
I mean, it looks good, I think.
Diana, why don't you just go over it quickly?
Yeah, so the IVUS shows that the stent looks well opposed throughout. We managed to achieve pretty good expansion, mostly symmetrical, and the areas that were a little bit asymmetrical, it appears that the area looks like it's adequate.
What's the area? Can you just measure it for them, just for the... So this is in the mid stent, I think. Yeah, 7.5, yeah.
Yes, great. Okay, so thank you so much, Fahim and your team. You have always been so supportive and do the case every year. Thank you to Boston Scientific for supporting this. We really appreciate it. Great case and excellent result. A big round of applause.
Thank you,
for
and thank you for inviting us, and all the best to a great meeting. Thank you so much.
We hope to see you here next year. Okay,
Inshallah.
so we are going
All
to
right.
end this session. Thank you very much, all the panelists, for excellent comments, and we are going to move on to the next session, which is an excellent CTO session by world-renowned faculty. And I would request Dr. Suhail Aziz to come here and to do the next session. Thank you very much.
जो मर्जी करो, second वाला